Hello, and thank you so much to the organizers of the 5th European Aniridia Conference for the opportunity to present this project. I will be reporting on a study of data drawn from the Wagner Syndrome Patient Registry and describe how we use this data to expand the characterization of this disorder and develop a model for care management in patients with Wagner syndrome. This project has been a joint effort of the International Wagner Syndrome Association, the Children's Hospital of Philadelphia, and the University of Pennsylvania. Wagner syndrome is a rare disorder with an incidence of about 1 in 1 million births and has long been characterized by so-called classic features of Wilms tumor, aniridia, genitourinary abnormalities, and a range of developmental delays. In addition to these classic features, obesity, chronic kidney failure, and a wide variety of non-classical features have also been reported. But the full phenotypic spectrum of patients with Wagner syndrome has not been well described, nor have these features been quantified in a large cohort. These additional features suggest a broader phenotype beyond the classic syndrome. We use data from the Wagner Syndrome Patient Registry to demonstrate this broader spectrum of features and to quantify the health issues that are common in this population. Participants and data for this registry were collected through the Wagner Syndrome Patient Registry, which is an online registry platform managed through a partnership between the International Wagner Syndrome Association and Coordination of Rare Diseases at Sanford. The registry is IRB approved and meets GDPR requirements. The registry consists of a 77-question survey completed by a patient or parent or guardian and covers the full range of body systems, as well as genetics, birth, and psychosocial information. Data in the registry is de-identified, and it is accessible to any researcher with IRB approval. Patients who enrolled in the registry between 2014 and 2020 and who had a diagnosis of Wagner syndrome were eligible for this study. Our Wagner Discovery cohort consisted of 91 individuals, including 52 females and 37 males, with participants in 16 countries. 66 participants were under the age of 18 and 25 were adults. This cohort represents the largest number of Wagner syndrome patients evaluated to date. The frequency of classic features are shown here. The most common feature in the cohort was aniridia, which was present in all but 2 participants. About half of participants reported Wilms tumor and/or nephrogenic RES. More than half were affected by a genitourinary abnormality, with males affected at twice the rate of females. However, it should be noted that the number of females affected by genitourinary anomalies is probably underappreciated, as internal genital anomalies are difficult to visualize in young patients, and until now, guidelines for care have not specifically recommended evaluation for these in females. Participants were frequently affected by cognitive and learning problems, and behavioral, emotional, and psychiatric conditions were also common. Findings in the category of ocular issues are of particular interest for this conference. As you can see, 86% of the Discovery cohort reported cataracts, 55% reported glaucoma, and 24% reported corneal keratopathy. Recent studies of patients with isolated aniridia have begun to examine the correlation of genotype and phenotype, with some indications that the ocular phenotype in Wagner syndrome may be the most severe. It would be very interesting to compare age-matched patients with isolated aniridia with patients in the Wagner syndrome registry, and we invite interested investigators to consider accessing the registry for this purpose. Also of interest for this conference is an association between Wagner syndrome and congenital anomalies of the kidney and/or urinary tract. In the WAGR Discovery cohort, close to 40% of participants reported a nephrourological abnormality, such as renal agenesis, duplex ureters, horseshoe kidney, or ureteral reflux. Mutations in the PAX2 gene are the most common genetic abnormalities found in patients with these anomalies. PAX2 plays a key role in kidney development because it activates downstream targets that ultimately lead to podocyte formation. Evidence suggests PAX2 strongly represses the expression of the WT1 gene, and conversely, WT1 is a PAX2 repressor. The role of PAX6 mutation on altered PAX2 function and optic nerve malformations has been suggested by other investigators. More research is needed to further establish the mechanisms leading to these associations. The frequency of non-classical health issues reported by participants in the registry was striking. More than 80% of participants were affected by respiratory issues, including frequent pneumonia, asthma, and obstructive sleep apnea. More than 75% were affected by at least one gastrointestinal issue, most often feeding difficulties or chronic constipation. Problems with the musculoskeletal system and endocrine and metabolic disorders affected more than 70%. Heart disease, kidney disease, and significant problems with sleep were present in more than 60%. So here we looked at the difference between characterizing the WAGR phenotype by classic feature on the left versus characterization by feature category on the right. Based on the registry data, we broadened the classic features into categories that included Wilms tumor and nephrogenic RES, aniridia and other ocular issues, and genital and nephrourological anomalies. In terms of patients presenting with all four classic features, only a third of the participants in the cohort had this phenotype. However, using the spectrum characterization, close to half had features consistent with the full WAGR phenotype. Also, historically, clinical diagnostic criteria for WAGR syndrome included aniridia plus one or more of the other classic features. Applying this historical criteria resulted in 90% of our participants meeting diagnostic criteria for WAGR syndrome. But applying spectrum criteria using classic feature categories identified 100% of the cohort. The results of the WAGR Discovery cohort demonstrate that clinical features far exceed the classical features that historically have characterized WAGR syndrome. Therefore, we propose a change in nomenclature from WAGR syndrome to WAGR spectrum to acknowledge the wide range of clinical manifestations in patients with mutations in this molecular region of chromosome 11p13. We believe this reclassification of the disorder will help to improve diagnosis and treatment of these many associated conditions, and that it will pave the way for more targeted research in the future. Parents and primary care providers have long sought evidence-based guidelines for medical management of this disorder. Using the data from the registry, we propose a comprehensive care management model with initial workup and core referrals based on common considerations in all patients, including management of aniridia and other eye issues, genital and nephrourological anomalies, behavioral challenges and neurodevelopmental delays, as well as the cardiac, endocrine, renal, and pulmonary abnormalities that are present in so many patients. Based on the frequency of additional health problems in this cohort, we suggest other specialists that may also be warranted. This table lists frequent issues and suggested specialists, as well as key considerations pertaining to each. For example, we observed a rate of hearing loss in the cohort of about 15%, a rate much higher than has previously been reported. As patients with Wagner syndrome are typically affected by low vision, preservation of hearing is crucial for quality of life, and so careful monitoring of hearing function is critical as well. Patients with Wagner syndrome face an increased risk for a wide variety of life-altering and potentially life-threatening health problems. We hope this care management model will provide a tool that both parents and providers can use to structure appropriate surveillance strategies that manage these risks, that allow for early detection and prompt treatment, and that this can optimize the lives and health of patients with Wagner spectrum. So what's next? Well, we're excited about the potential for additional research on the data in the registry, particularly because the number of participants has increased by more than 60% since this project was completed, from 91 patients to more than 140. We also hope to explore the possibility of clinical studies to investigate correlations between genotype and phenotype in aniridia associated with Wagner spectrum, as well as to explore ways to improve diagnosis and treatment of all the conditions that are associated with this disorder. And finally, I'd like to thank the remarkable team at the Kalish Lab at Children's Hospital of Philadelphia, my fellow collaborators in the International Wagner Syndrome Association, and most especially the Wagner spectrum families around the world whose participation in the registry made this project possible and whose continued support drives research forward. Thank you so much.